talking today about specialized care for early episode psychosis, shifting the outcome curve, which will relate both to our clinic and to the concept of treatment of individuals in the early stages of schizophrenia more generally. Only this partial disclosure. Objectives are here, but will be, I think, clear when we go through aspects of this presentation. I'm going to start with acknowledgments so I don't forget them. A long list of people in our clinic who have made a major difference in the lives of our patients. Leadership at Bayview, who has helped establish this clinic. Jill Mersteller at the Bloomberg School of Public Health is part of our network. This whole early psychosis operation at Bayview is really the brainchild of Krista Baker, now an administrator in the Department of Psychiatry at the University of Arizona, and the principal investigators of the Connection Learning Health System, our network that we're part of, are Dr. Melanie Bennett at Maryland and Monica Calkins at Penn. Lots of funding from NIMH and from private sources and from the states of Maryland and Pennsylvania. So I'm going to start with some definitions and caveats, because we're going to be talking about first episode psychosis. And exactly what does that mean? The best definition I found was in a memo from the New York state government saying it is psychotic symptoms suggestive of recently emerged schizophrenia that have emerged within the last 2 years, and it includes individuals with the diagnosis of schizophrenia or other diagnoses on the schizophrenia spectrum like schizoaffective disorders and the like, and excludes individuals whose psychotic symptoms are due primarily to mood disorder or substance use. The problem is this term takes on different meanings in different contexts. So particularly the diagnostic limitation is often ignored, and there's often a different stipulation of the time frame for onset. So it makes understanding the clinical practice and the research somewhat less than crystal clear. The rationale for the focus on first episode psychosis began to emerge in the 1990s with the development of a critical period hypothesis, that there was a time early in the stage of the illness where both biologic processes and psychological and social processes were all at a period where they could be improved much more than later in the course of the illness. Other reasons for a focus on first episode psychosis was the high suicide rate, which we know about in schizophrenia, but was found to be highest at younger ages. Findings that longer duration of untreated psychosis led to worse outcome. Belief that engagement of individuals was easier earlier in the course of illness. Comorbidities could be best tackled early. Diagnostic clarification could be handled by focusing early in the course of an illness. Stigma and trauma could be reduced by a more positive early contact with treatment rather than involuntary hospitalization and the like. Costs could be decreased in the long run through decreasing healthcare utilization, disability claims, homelessness, and legal involvement, and that it might be possible to address inequities by prioritizing care for marginalized groups. So this term of first episode psychosis began to emerge over time. In the 1980s, it was first recognized that long duration of illness led to worse outcomes. In 91 and 92, the National Institutes of Mental Health and the International Congress on Schizophrenia both held meetings on first episode psychosis, and there were issues in the lead journal Schizophrenia Bulletin dedicated to the topic. In the early 90s, Australian programs that were successful in treatment of early psychosis focused tension on the concept. An association is founded. Landmark trials in the early 2000s showed benefits for treating early psychosis. And by 2013, DSMI formalized first episode as a course specifier, and since then, various funders and health systems have adopted the term FEP for program design, performance metrics, and eligibility. So whether we like the term or not, it's here to stay. This is an example of what's happened with publications with citing First Episode Psychosis going from about 0 in 1990 all the way up to hundreds every year at this point in time. The problem starts, though, with the term psychosis. There are really 4 different uses, I think, of the term. The lay use is something like crazy or bizarre. The old psychoanalytic use, which I think still has some value, is detached from reality. It's often used as a synonym for schizophrenia, and the more specific use that we use here as much as possible are the presence of hallucinations, delusions, and our thought disorder, disorganized behavior. The problem is that first episode psychosis clinical practice and research is often kind of an amalgam of definitions 2, 3, and 4, which I think leads to confusion at times. There's also a problem with the term first episode, because the onset of schizophrenia and other diagnoses is often gradual without a clear starting point. Operational definitions vary. When does an episode begin? The first hospitalization, the first treatment, the first medicine, the first symptoms. It also tends to lead to a focus on positive symptoms and less so on negative symptoms or cognitive symptoms, which actually may be more impairing. The concept of episode assumes a waxing and waning course with remission, which may or may not be the case in particular individuals. So alternatives exist, recent onset psychosis or early phase schizophrenia, but they have not caught on. So first episode psychosis it is. I want to switch now to the concept of coordinated specialty care, the kind of clinic that we run at Bayview, and talk about its history and evidence of its effectiveness. So this term was first coined in a 2014 NIMH report on evidence-based treatment for first episode psychosis. And the idea was that there would be recovery-oriented team approach, easy access care, and shared decision-making among specialists, the person experiencing psychosis and their family. There are multiple variants of what constitutes coordinated specialty care, but they all include, to a greater or lesser extent, family support and education programs, medicine management, supported employment and education services, individual and/or group psychotherapy, case management, and peer support. So this term is also one that, even though it's kind of vague, we're going to have to use. There are interesting exclusions for most coordinated specialty care clinics, and that is people with developmental disabilities. And the rationale is that the services and the philosophy of CSC is aimed at recovery, meaning a return to previous levels of function to the maximal extent possible, be it education, employment, and social activities. And the consequence is that there's often a lot of tension concerning referrals of individuals who have significant developmental disabilities, but also signs and symptoms consistent with schizophrenia. And it leads to individuals being referred to our clinics who we will refer elsewhere because of this definition, which in part we're obligated to do because of state funding mandates. So the path towards CSC, Coordinated Specialty Care in the US, began, I think, with the success of the Australian Early Psychosis Prevention Intervention Center, which was published by Patrick McGorry in 1996, and he's since become a leader in this field. There were successful trials in the UK, Denmark, and Norway in the early 2000s, leading the United Kingdom to change its policy to support early psychosis clinics, CSC model. And the big event in the United States was in 2008, when the NIMH launched the Recovery After Initial Episode program, the RAISE program, which we'll refer to repeatedly after this, with the goal of finding the best approach to recovery, decreasing future episodes of care, and decreasing long-term disabilities. Shortly thereafter, the first study in the United States was published that showed improvement in individuals treated in CSC, though it was not controlled. Congress then mandated SAMHSA to fund early intervention services so that 5% of mental health block grants given to states had to be spent for CSC-like programs, and this made a big difference. In 2015, the RAISE studies in the United States, which gave controlled evidence of value of CSCs were published. And in 2016, SAMHSA, Congress mandated that SAMHSA increase CSC funding and state block grants to 10%. And here's the key study. This is, I want to spend a few minutes on this because it is really a landmark in the United States. This was the RAISE study looking at 2-year outcomes led by John Kane, a well-known expert in pharmaceutical trials and many other things, and also led by individuals from the National Institute of Mental Health, a real team effort. The goal was to determine if multimodal, multidisciplinary care of first episode psychosis is superior to standard care, and to see if what worked in European countries with nationalized health system could work in the United States in non-academic community clinics. The basic design was to look at 34 clinics in 21 states treating 404 individuals who had schizophrenia or a related disorder during a first episode, less than 6 months of antipsychotic treatment. And so clinics were signed, not the patients, but entire clinics were signed either to Navigate, which was a model of CSC care, which I'll talk about in a moment, versus standard community care. And outcomes were measured at 2 years, with the primary outcome being a quality of life scale. So here's the basic program. It's called Navigate. Here's the basic protocol with 4 core interventions and, of course, lots of other things, but medicine management, family psychoeducation, resilience-focused individual therapy, and supported employment and education, also peer support. This is basically the model that our clinic uses. Here's the outcomes. They're modest but meaningful. First of all, they found that individuals who were treated with specialized care were more likely to receive key services, remained in treatment longer, and received more services each month than individuals in standard community care. The primary outcome measure, while showing a modest effect size of 0.31, nonetheless showed an improved quality of life in individuals receiving CSC care rather than community care. And you can see at the beginning, here's the people receiving specialized care. This is the higher on the scale you are, the better your quality of life. And they started out somewhat lower than the individuals in community care, but ended up higher, and that resulted in a small but significant difference. Also, symptoms improved in the same way, where individuals receiving specialized care started off with a PANSS score in the mid-70s, which is fairly ill, and fell to the mid-60s, more so than individuals receiving community care. Again, a modest effect, but significant. There was also improvement on depression and the percent of individuals who were working or in school, though there was not effect on global clinical indexes or on the percent of people hospitalized. So it was a modest effect, but a positive one. This led to this remarkable expansion of CSE specialized programs. So our first clinic was launched by Krista Baker in 2008, and because there were no grants available, it was limited in the services provided, but we did specialize in individuals with early psychosis. Affordable Care Act provided more access to care. The federal block grants in 2014 and then 2016, the increase really, I think, sped things along their way, as did the data. So now there are hundreds of clinics in every state and territory in the country, still far fewer than is needed for the actual number of individuals with illness. But it's really a remarkable example of a research to practice translational timeline, showing the effect of data, clinical wisdom, and government stimulation all working together in a positive way. The longer-term benefits of this kind of CSC program was investigated using the population that was originally studied in the RAISE study. They looked at outcome for a total of 5 years, meaning individuals who had about 2 years of treatment and then an additional 3 years without specialized treatment. And they found that in a limited sample, because only 30% of the original 400 people were available to be assessed by 5 years, Nonetheless, after a lot of controls, this is a very sophisticated study, that the quality of life became increasingly better over 5 years for individuals who'd had 2 years of treatment. And the treatment's in here. This is without specialized treatment here, but yet the effect of the early intervention appeared to be effective, and symptoms also dropped. So quality of life improved, symptoms became less even after the treatment had stopped, suggesting indeed something about this critical period, whether it be biological or psychosocial. Also, of course, cost effectiveness was examined, and there was an entire SAMHSA report dedicated to this, looking at early intervention services, which is another acronym for CSC-like programs, EIS. And one study they examined was the OPUS study of early psychosis treatment in Denmark, and showed that the probability that it was less costly and more effective was 95%, depending on what the ceiling ratio of how much you were willing to spend on a case was. Other smaller studies also tend to show a savings, mostly because of reduced hospitalization costs. The EPIC study in Australia suggested a 1/3 reduction in costs. The Leo study in South London suggests costs were equal, but the treatment was more effective. And the Parachute study in Sweden suggested a decrease in costs. So there's variation by clinics, and of course populations are different and healthcare systems are different. But the general conclusion has consistently been that providing services, even though the services cost, let's see if I wrote it down. Nope, services cost somewhere around $1,200 to $1,500 a month per person, nonetheless pay off for health systems. So bear that in mind. All right, so the next step in developing community coordinated service care was the EpiNet program. And that's what I'm going to talk about next. So this was a program launched by the NIMH in 2019 that has funded 8 networks or hubs designed to each have 10 or 20 or so different clinics within their hubs, and that each hub would be responsible for generating data and learning about the strengths and weaknesses of their care systems to provide better quality of care for coordinated specialty care overall. Each clinic collects standardized clinical data and sends it to a central location in their hub, and data from each hub is deposited into a central data bank, which is the largest First Episode data bank in the US, and it's all funded by the NIMH, and the funding was actually renewed for a second cycle in 2024. We're one of these hubs. We call ourselves the Connection Learning Healthcare System. It was going to be the Mason-Dixon line system, but we're worried that we might add Delaware and it'd get confusing at some point. It's 23, it's all community coordinated specialty care sites in the states of Maryland and Pennsylvania, which amounts to 23. It just went down to 21 because Shepherd Pratt declined to accept the state's grant offer. So leaving Montgomery County and PG County now underserved, though they're going to be offering a request for proposals that maybe we should consider. It includes our 2 Bayview EPIC clinics, 4 academic institutions, Hopkins, Maryland, Penn, and Pittsburgh, 5 hospital systems, Shepherd Pratt, I guess it's now 4, 2 state behavioral health systems, all having to work together. And the aim was to create a 2-state learning healthcare system which collects standardized core assessment batteries to conduct practice-based research. We were funded in 2020 for 4 years and refunded in 2024 for another 5 years under the leadership of Melanie Bennett and Monica Calkins. You can see this is where all these different clinics are located. It turns out if you're in the Baltimore area, you're in good luck because we have 4 clinics right within the Baltimore metropolitan area. If you're somewhere out in the middle of Pennsylvania, not so lucky. And this is a problem in general for specialized care for schizophrenia. There are big gaps based on geography. So One of the things that we collect from every patient at admission every 6 months is what we call the comprehensive assessment battery. This is where having a research coordinator embedded within our clinic, Rachel, who nudges us and makes sure everything is organized, makes a big difference. So we collect, of course, standard demographics, but a whole series of rating scales that are either clinician assessed or self-report measures on symptoms and function and satisfaction and side effects, family issues, sleep issues, all of which is stored in data where we have access to it for each individual patient so that we can see how our own patients are doing, and it's stored in an anonymized form in a centralized hub, which is maintained at the University of Maryland, which allows us to do a lot of research projects. This is the list of research projects currently underway in our hub. There's 34 of them. The ones in red are ones that have been published. The ones in yellow have been submitted or in revision. And I group them arbitrarily into different categories of medicines, behaviors, life trauma, symptoms and diagnosis, legal and benefits issues, ethnicity and minority issues, and program development and tools. And the goal is for us to engage every single clinician in our program, regardless of whether they've had research experience in participating in these studies, thinking about problems that might need to be examined, and then afterwards discussing the results and using them to improve the care, hence a learning health system. I want to focus on just 2 examples of research projects that have particular implications for our practice, both within our hub, within our clinic, within our hub, and within early psychosis treatment more generally. The first is tobacco, and this is a study that's been published. It was led by Melanie Bennett and Faith Dickerson, who I think may be on our part-time faculty, and is an expert in, both of them are experts in substance use in the setting of severe mental illness. And what they found is that in the last, if you look at just at tobacco smokers, that's here, there's a 35% lifetime use in our individuals in our hub, which in their case was, I think, 400 or 500 people that they studied at the time, and about a 20% rate of smoking in the last 30 days, which is double the background of a comparable age group in the US. Nicotine vapors was less different, about the same as the background. And the idea here is that this is a real major problem. We know that individuals with schizophrenia have major health problems and morbidity and mortality rates that are really quite shocking, and it really suggests the need that we have to implement smoking cessation programs within our system and make it a major effort. Just an example. I want to spend a little bit more time on clozapine use, since this is also an interest of many of us in the department. This is a study still in progress where the lead is a medical student who decided to go into emergency medicine instead of psychiatry, despite my best efforts, Ethan Mondell. What we know about clozapine use in early psychosis is that 25% of individuals will eventually develop treatment-resistant schizophrenia. That clozapine is most effective when it's prescribed earlier, and it's used at most in about 7 to 10% of first episode patients, often with a long delay. And little is known about the factors influencing clozapine treatment in first episode clinic. So our objective was to determine the demographic and clinical characteristics of patients prescribed clozapine versus other treatments in our network. What we found, taking 1,183 individuals for whom we had sufficient data, not correcting them for duration in the program, which is an issue because patients taking clozapine tend to stay enrolled longer. What we found is that 2.7% of patients were taking clozapine at admission, 4.1% were prescribed clozapine sometime during their enrollment in the program. So the total rate of 6.8% of prescribed clozapine is generally consistent with the overall underuse of clozapine in the population. We found a couple other interesting things. One is that while there was no racial disparity in the number of patients already on clozapine admission, there was a really marked disparity in people who, in the prescription of clozapine for people after they were enrolled, so that there were 3 times more clozapine prescriptions in white patients versus black patients for reasons that were not explained by symptom differences. Though we did find that insurance was a mediating factor for which we don't understand, but individuals with public insurance received clozapine at the same rate, whether they're white or black, but individuals with private insurance had a markedly different rate of receiving clozapine. And I still don't understand that difference, but I suspect it reflects some pretty complex sociodemographic factors. We also found that there was a very large difference in clinics' use of clozapine. So we looked at 18 clinics that had at least enough patients on, contributed 2% or more of the total patients of the cohort. So we excluded some of the very small clinics. And we found patients taking clozapine admission ranged from 0 to 11% of total enrollment. But the key thing was that there was a range of subsequent prescription of clozapine from 0 to 22%, a highly significant difference from high to low clinics. For reasons, again, we don't fully understand, patient population, clinic choices, clinic comfort with clozapine, but it suggests future actions that may help us in our clinics to increase the use of clozapine and eliminate disparities. First, we should examine qualitative studies of clinicians and patient attitudes, especially after the REMS requirements for clozapine prescription have been eliminated. Maybe individuals, clinicians need access to consultation, and maybe any patient who is placed on a 3rd antipsychotic or who has rating scales indicated prolonged high symptoms or low functioning should at least be reviewed for possible clozapine use. The point is that these are kind of studies that can be done within our system, so it becomes an iterative process of discovering issues and working to refine what's going on and then working to implement possible solutions. There's one sort of down note to all of this, and that is that one of the best studies that's ever been done on really long-term effective early intervention suggests that after 5 years, the effect of a couple years of comprehensive treatment begins to fade away. So this is the OPUS study from Denmark, which showed at 2 years that negative symptoms were less. This is the dotted line to the orange line here. Negative symptoms were substantially less in people receiving comprehensive treatment, coordinated service treatment compared to community treatment, as well as positive symptoms, but that effect was gone by about 10 years. And they found in the long run no differences on education level, living conditions, cognition, use of antipsychotics, self-rated physical or mental health, quality of life, symptom remission, or clinical recovery at 20 years of follow-up. So that's a concern. And the same thing is true with mortality, which remained quite high regardless of whether individuals were receiving the comprehensive treatment or treatment as usual. And the implications there are pretty important. It suggests that early intervention does make a difference during and for a few years after the end of comprehensive treatment, but the effects tend to fade away, suggesting that there's heterogeneity because some patients clearly do well with symptom remission and strong recoveries, but that means that other patients don't do well. So it clearly means we need to be able to figure out which patients are going to need longer-term services, determine which services will be necessary to maintain progress, and support and implement such programs. So we have a partial way of addressing this at Hopkins that I think represents a useful model and a model that still needs to be developed. So we have our EPIC RAISE program where we have the full range of services because the doctor and therapist can bill fee for service, usually with Medicaid, sometimes private insurance, and then state grant supports other clinical support individuals. For individuals who either age out of epic rays or for some reason do not fit the strict state definitions that are required to be enrolled, we have our other clinic, which does not have all the support services, but does have a physician and therapist with expertise in early psychosis clinic. And then Bayview has the unique advantage of having an adult schizophrenia clinic for which individuals who complete care over several years in these clinics and no longer need intensive care can be changed over to a less intensive adult schizophrenia clinic or other Bayview or sometimes Johns Hopkins teams such as a mobile treatment team, Creative Alternatives, the capitation program, and other clinics as relevant. So this is the kind of model that can, I think, help solve some of the problems of longer-term care. But we have challenges. These services are supported by state grants and are not available outside of the very specialized clinic like Epic Ray's clinic. The aging of the population is likely going to require geriatric schizophrenia care. Seamless vertical care is challenging. Capitation and mobile admission criteria can limit ideal care, and loss of engagement early in treatment still remains a problem. And of course, there's the broader challenge that there's lack of access to specialized care over the country. There needs to be improvement in the structure and service, as some of our studies have shown, and there's a real limited availability of post-early psychosis specialty care, and of course, the overwhelming threat, kind of the huge black X over everything, is that Medicaid and SAMHSA really face existential threats in being able to provide these sort of services for patients. So the rise of specialized care for first episode psychosis over 20 years is a remarkable example of clinical need, scientific study, government support. EBNET provides another approach to improving CSC care. Ongoing studies demonstrate the value of having a network that can serve as a learning health system. CSC care may gradually lose effectiveness, suggesting the need for flexible post-early psychosis clinic treatment, and there are structural solutions that can be used to optimize service delivery, but these are under threat. So I'll end with that.
Thank you, Dr. Margolis. This seems like a really great thing, having this kind of comprehensive program, and the fact that there's that these have proliferated is a real positive. You mentioned towards the end this issue of the threat of loss of engagement, which seems like one of the big challenges in dealing with this illness. It seems like having a whole bunch of services means you have a lot of opportunities to try to keep keep patients engaged. Is there any data saying that engagement is actually improved?
Well, it turns out that the entire focus of our second 5 years of funding for our network is engagement systems, so that we have developed a calculator for predicting who might become disengaged, and we're developing a team, what are we calling them, navigating team or some such, that will be involved as neutral parties to help with engagement. So the data is certainly, yes, the service provisions like having somebody like Selvin who can meet people on a one-to-one basis as providing peer support makes a huge difference, but that it still needs to be improved, and we're working on it.
Great, thanks. Other folks have questions? Dr. Margolis. Is that Dr. Morrow?
Yes, indeed. There is a long-standing program called the NAPLES study, National North American, I don't know, Psychosis Before It Happens study. I don't remember what the acronym stands for, but they have worked for years to look at individuals at high risk, either because their parents have a major mental illness or they've had minor symptoms, and to be able to predict who is going to become ill using either clinical markers, imaging, AI-based analyses of multiple factors to determine who will get ill, and if so, will early intervention help? At the present, basically the standard of care is you treat the person in front of you. So if someone doesn't have risk factors, but doesn't have, say, full-blown hallucinations, illusions, etc., it is not the current practice to give them antipsychotic medicines, but that could change either with better medicines or with better predicting capacity.
Thanks. Other folks? Dr. Paula. Thank you. Dr. Lipsy. Thanks, John.
Right. Dr. Lipsy's question is about ECT and the use of individuals who appear to have schizophrenia, given the fact that, one, there's big overlap in presentations change, and there's actually the simple fact that individuals with clear-cut schizophrenia can sometimes respond to ECT. So the answer is, if someone doesn't respond to standard treatments, including clozapine, then ECT is indeed warranted. So the answer, I would say, is yes, not necessarily early, but as a fourth-line treatment.
Thank you. Other questions? Oh, yes, go ahead.
Sure. One person, what I would always do is tell somebody, call Max, who coordinates the program, to make sure before you begin.
Wait, tell us Max's last name.
Wolcott.
Max Wolcott.
Right. Because there turns out there's limitations, there's all practical things, and before getting a person's hopes up, or their families in particular, one wants to make sure that the practical issues aren't insurmountable. But then, I think it's a pretty straightforward issue if you said, look, things are complicated here, and I think it might be helpful for you to have a broader treatment approach that might be possible in one of these clinics. I think that that's not a difficult conversation once you've cleared the logistics.
Let me ask one last question. Are there any plans to test Cobenfy within the network?
Not. One can propose to do anything within the network. It just goes through a committee that approves it, and I'm chair of the committee. And so,
well, you're the right person to ask then.
yes. I can tell you that our group is going to be looking at Cobenfy in a naturalistic way. Basically, this is not within our early psychosis group, but it's a study that Fred Nucifora will be leading, where we're going to look at anybody who started on Cobenfy and follow them along to see if it is of value. So, no specifically yet in CLHS, but yes in our system here at Hopkins.
Well, let me just finish up by saying that we will be celebrating Dr. Margolis' new endowed professorship. He'll become the ABCD Charitable Trust Professor of Schizophrenia. Is that next week or the week after?
Next week.
Next week. All right. So be there in the FIPS lobby. All right. Thanks for a great grammar.